Back for round two with Tom Jesson. It's been a while since you were on for the first episode. I think it was all the way back in 21 and it was episode 39. Thanks for round two, Tom. For people who aren't familiar with you or haven't listened to that first episode, can you tell people a little bit about yourself?
Yeah, certainly. Well, first, thanks for inviting me, Chris. Appreciate it. It's nice to be back. Especially, I'm just remembering you guys have the one good video on sciatica on YouTube. And it's very good. It's fantastic. So it's good to kind of work with you in that respect. But I'm a physical therapist or physiotherapist. I'm from England originally, from the north of England, but I'm in Houston right now. So my wife's American. Everyone says, well, how did you end up there? My wife's American. That's a short version of that story. And, you know, the reason I'm here is I've kind of accidentally made sciatica or lumbar radicular pain my specialty. I started reading and writing about it. I guess in earnest, it was one of those COVID things when everyone was kind of looking for something to read, and I started writing about sciatica, and people found it quite useful. I think it's one of those topics people realized they don't know quite a lot about it, so I kind of went with that, and then it's kind of 2 books and plenty of articles and papers since then. I've got quite a lot under my belt, so that's me, and hopefully have something to help you with today in terms of the neuro exam.
Do you ever get tired of writing and researching sciatica?
No, I don't. So it's endlessly interesting. It's kind of fractal. Like the more you go into it, the more new stuff you find, which is obviously quite dangerous because you can spend a lot of time on the really technical stuff, which actually isn't clinically useful. But there's so much there. There's so much going back easily 150 years where people are writing really useful, interesting stuff. So I feel quite lucky that I found something to really get my teeth into. And I suppose it's one of those things compared to like non-specific low back pain where no one knows what's going on with that anymore. Like everything's so up in the air when it comes to sciatica. There's actually quite a lot of stuff to talk about there that we do know. You never say for certain, but there's stuff that we know and that we can work with. So for that reason as well, it's a nice topic. Yeah.
If there was one researcher or research group or book that has shaped your views of the landscape of the research or sciatica in general, is there one that comes to mind?
I think that's difficult to say shaped. I think at the moment, at the moment, actually, one of my co-authors, Anina Schmidt, is doing wonderful work. She is in Oxford in England. She's a physiotherapist by background, and I don't know now, so she'd call herself a neuroscientist. But she does really well in terms of the kind of really technical, detailed microbiological stuff, and linking it to the clinical stuff. And she's written a lot actually on the neuro exam too. I think she's doing wonderfully well. I'm kind of interested how I'm a bit stumped to think of like many other people who've really shaped it, who are still going. Because actually one of the really interesting things is the good stuff is the old stuff. Like the old ones are the best. And there's some fantastic papers going back to the 50s and where they're kind of opening up people's spines and just pulling and tugging on stuff to see what hurts, and while they're awake to see what hurts. Does this cause sciatica? Okay, what about if I prod here? Is that sciatica? That stuff really is great. And then there's kind of a series of animal studies from like the 80s and 90s where they really like formalized that on poor unfortunate, mammals, pigs and rabbits and stuff, where they're trying to work out, what exactly causes this condition. So I guess that's a stab at the answer, but in terms of kind of shaping the research, I suppose that was where I would go. Of course, the OGs are Mixter and Barr from like the 30s. They're the people who discovered sciatica. Essentially, that's not right. They discovered that the sciatica was caused by a disc herniation most of the time. And before then, people didn't really know what it was. They thought it was maybe like a benign tumor, like a lump or a bump or something like that. But they actually were the people who went back through all their previous cases. So I should say that, these Mixter was a surgeon and he was a bar, and he'd been operating. People were operating on sciatica to remove disc herniations, and they had been for decade or two. But no one really knew what it was. They were just opening people up and taking out this gunk. And like I say, they thought, oh, maybe it's a tumor or something. And they were the first people to kind of go back through these cases and actually look at what is this stuff we've been taking out of people. And they realized, oh, it's actually herniated disc material, which hadn't really crossed many people's minds. So they were the first people who discovered that it's a disc. And then that kind of formalized the idea of a discectomy for sciatica, which is probably one of the major big leaps forward in musculoskeletal medicine, like in a field where notoriously not much works that much. It's a really good surgery, especially for people who are losing their nerve function rapidly. But on the other hand, it ushered in what they call the dynasty of the disc, which we're still dealing with, where everyone thought, okay, so you're saying all back pain is the disc? And we had 80 years of disc everything. So maybe those are the answer to the question.
Well, today we're not going to dive specifically into sciatica.
You shouldn't have asked me about that.
I was curious.
Could have gone on for 2 hours.
Yeah, I'm sure a lot of those older papers, obviously you mentioned it, you can't do a lot of those studies now, but it provided a lot of information when they did do it. We're going to dive into the intricacies of the lower limb exam, and you wrote a zine on this. Can you briefly touch on what a zine is for people that don't know?
Yeah, I had it because I knew you'd ask me. I was like, well, this is a zine. I started making these zines. I'm holding up to the screen. You print it off your computer yourself, and it looks like a kind of messy cartoon book, basically. And zine is short for magazine. That's where the word comes from. It's pronounced zine, and I basically describe it as a DIY cartoon. They're famous, I guess, from counterculture in the 70s and 80s, and still currently, where it's okay, if you didn't have a printing press or people weren't going to print your stuff, and you're into punk rock or something, then you draw it, and then you can just print it off yourself, and you fold it up and stuff and distribute it. So having published 2 books and slaved away on getting every illustration perfect and actually getting the thing printed and looking right, I was I'm not doing that again. So I deliberately chose something where I could be a little bit more casual in the drawing style and the writing style. So I can kind of do these a lot quicker, and people like them more because they can actually read them as well. They're not reading a book. Let's face it, most people don't end up getting to the last page, but these people actually read them. So
yeah, they're super digestible, and the art. So do you draw all the art on those zines?
Yes. Yeah.
Wow. Yeah, I was curious when I was looking through it. Is it you hired someone to do it, or is kind of created on its own? Wow, good work. That's nice.
Yeah. So I know you want to get going, but just to briefly say, I'll put a promo code on my website. So if anyone wants, we're talking about Neuro exam today. So if anyone wants to download the one in the Neuro exam, I'll put a promo code E3 Rehab. Let's just say lowercase E3 Rehab, and they'll just give that for free. That's fine. And then if people like it and if it suits, then they can get the other ones. But
awesome.
If people are wondering, they could just read along on the screen. They don't even have to print it out as I'm talking and look at the pictures. So.
Yeah, totally. Thanks for doing that, Tom. So let's dive into it. The main topic will be a lower limb neuro exam, and sometimes that helps you identify that this is sciatica. And for those that want more information on sciatica, listen to the first episode and you can dive into it from there. But it can also lead you into a lot of other paths and diagnoses and treatment algorithms. So let's start with, what is the actual purpose of a lower limb neuro exam, Tom?
Broadly speaking, the lower limb or any neurological exam, the purpose is to identify a loss of nerve function. So when we think about nerve problems, whether the nerve is squashed, inflamed, we think about there being 2 directions the problem can go in. There can be a gain of function, which is when a nerve is excitable or jumpy and it starts firing off too many impulses. So we think about with sciatica, that's an a nerve root in the spine, and let's say it's a disc herniation, irritates the root, you get a gain of function, and the root starts to, this is a metaphor, fizz and crackle, almost like a broken wire, and it sends off all those impulses to the brain, and we feel that as pain and pins and needles. It's like a gain of nerve function, too much activity. When we do a neurological exam, with our reflex hammer and all that stuff, we're looking for a loss of nerve function, which is when the nerve is not working as much as it should. So if we take reflexes for an example, we tap on someone's patellar tendon and it sends an impulse. It should send an impulse up through the nerve root to the spinal cord, and then that should be passed on and down back to the quad. If someone has sciatica and they have a loss of nerve function, then that impulse will not get through the nerve root in either direction, and it won't get back down to the quad, and they will have an absent reflex. So same for a sensation. If we touch their skin, say on the front of their knee, usually that impulse will go up to their brain and they know that you're touching their skin. If they have a loss of nerve function, then that nerve is too damaged or too squashed to take that impulse up to the brain, and it won't get there. Of course, most people, or many people I should say, will have a loss and a gain of nerve function. So the nerve will both be irritable and causing pain, and also not able to carry the impulses up and down between the brain and the leg as it should do. But when we are doing the neurological exam, we are looking for a loss of nerve function. And then you say, I guess the next question is, well, why are we doing that? Broadly speaking, we want to do, I suppose we could say, three things. One is we want to screen them for any serious stuff. So loss of nerve function is obviously can be potentially quite a serious thing. As a physiotherapist, the loss of nerve function might be so bad that I don't want to see them, and I should send them as an urgent or emergency referral to someone else. So we're kind of trying to screen our patients for a serious loss of nerve function, or even just a loss of nerve function that isn't consistent with something a physio should manage. So maybe they have, we suspect they might have a type of peripheral neuropathy that might need medical intervention, in which case we might want to refer them to a doctor instead, or as well as our care. So we're trying to screen them for a loss of nerve function that means that we should either be watching them and stewarding them very carefully, or that we should just be referring them to someone else immediately. As well as kind of screening and stewarding them, we want to use what we find in the neurological exam to help diagnose or classify that patient. Obviously, there's lots of philosophical debates about to what extent do you or can you diagnose and classify people. But I think most people would agree that to a certain extent, we want to put patients at least in some kind of bucket where we're saying, this seems like sciatica, so that's what we're going to go with for now. This seems like this seems like that. And, we can go into more detail. So we want to diagnose and classify them. And the last reason to do a neurological exam is it's an extremely good opportunity to educate and reassure your patient about what's going on. So it's kind of that thing in between. Well, it's obviously a physical assessment, but at the same time, it's extremely interactive. It's verbal. So you're talking to the patient and you're moving their body and you're asking, how does this feel? What happens if we do this? So it's a great opportunity to get a little bit of education in there and explain to your patient what's going on, because especially when people have nerve issues, they're typically very worried or confused about what's going on. And it's very reassuring because, to put it, maybe sounds a bit blunt or cynical, but if you've got your reflex hammer and your cotton bud and you're checking sensation and myotomes and all that stuff, it appears, but it also communicates to the patient that you're being thorough and respectful and that you're giving them an in-depth assessment. So it's also a very reassuring thing for patients to be assessed, usually, in this manner. So lots of reasons to do it. Screen them and steward them, diagnose and classify them, and reassure them and give them some education too.
Yeah, to that last point of feeling like you're paying attention, you're being thorough, you're providing confidence and reassurance. That's the ideal situation. But a lot of new grads or clinicians that don't feel comfortable with a neuro exam, it can do the opposite. And it can make you, as the clinician, feel uncertain and nervous, and you don't have a flow, or you don't know why you're doing it. And then that can kind of bleed into the patient's perceptions and make them more scared potentially, or more uncertain. So the goal today is to feel a little bit more confident as to why people are doing it and better ways to go about this process. Starting to the screening and stewarding, you had mentioned some of these things already, but you had touched on this in the first episode, the 3 Ps of nerve function that you're really looking for as when to refer out, or when this may be enough loss of nerve function to, seek other care or specialty care. Mm-hmm. Can you discuss those 3 Ps, Tom?
So again, we're thinking as a starting point that, our patient has low back related leg pain, so that, their back hurts and it's going down their leg, or they have leg pain we think might be coming from their back. It's generally accepted that, if you find, that it's actually quite common for people in this position to have a neurological loss of function. So it's quite common for people with back pain and leg pain, let's just say sciatica, to have a patch of numbness on the top of their foot, or to not be able to do as many heel raises on one leg as they can on the other. And there's no cause for alarm. That's actually one of the biggest benefits, I think, as a physiotherapist. I know you have all sorts of clinicians and types of therapists listen to your show, but as someone who's a physio or a chiropractor who's kind of really trained in this stuff and knows this stuff, one of the biggest benefits is we can confidently say and help our patients through that process. I've seen this before. I know roughly what's going on. We can never have MRI vision. It's kind of accepted that people will have some loss of function. It's also accepted that if the loss of function is bad enough, then we need to refer them to someone else. Usually, obviously that depends on where you work, but a doctor or a surgeon, or someone who can order a scan. I'm just assuming that listeners can't, to investigate further. And then it's just the 3 Ps are just an attempt to explain exactly what bad enough means, because I think it's kind of people, well, how bad is bad enough? If someone has a loss of nerve function when you do your exam that is profound, progressive, or seems to be polyroot, then we can say that is bad enough for you to at least strongly consider referring them on. By profound, I mean someone who has anything less than a 4 out of 5 muscle strength on the Oxford grading system. So 3 out of 5 or less. And that's a very general, listener discretion, advised, like anything I say, of course. But, if they can dorsiflex their ankle against resistance, then they don't have a profound loss of function. If they can't, if you give them minimal resistance with your hand and they can't push against you, we can say that's a profound loss of function. They're getting into foot drop territory. Depending on where you work, there might be like a specific thing you need to do for that, but you almost certainly need to do something. The loss of function might be progressive, in which case that's another reason to kind of raise an eyebrow. Maybe you see them 1 week and the next week, or if you're in the NHS, 1 month and the next month, and their loss of function is getting, progressively worse. Maybe they're not at foot drop territory yet, but it's getting weaker. That means that we should, again, be on high alert and consider getting someone else involved. And finally, polyroot is, which is, again, to a certain extent, loss of function is expected. If someone has like some ankle weakness, then that's expected. It implies that they have one nerve root that's damaged, like the S1 nerve root might be damaged. But if someone has ankle weakness and, let's say, plantar flexion weakness and knee extensor weakness, then at least in your mind's eye, you're saying, well, okay, so S1 is damaged potentially if their plantar flexion is weak. But if their knee extension is weak, then that's kind of more L4. So if there's something going on with S1 and something going on with L4, then that makes me concerned that actually something quite big is happening in the spine. Is there a big disc herniation? Is there a big tumor, heaven forbid, something metastatic? You don't know. But the point is that any single level root is kind of expected. Just to confuse things, we know that the roots aren't perfectly wired. So actually, like if maybe someone has plantar flexion weakness and a bit of weakness in dorsiflexion, that's expected too. Everything overlaps. But when you start to think in your mind's eye, hang on, we have like 2-3 different levels of problem here, whether that's strength, sensation, reflexes, then you're starting to, again, I like this phrase, raise an eyebrow, because it doesn't mean you're like banging the red button, oh my God, get this person away from me. But you're thinking something doesn't match here with what I would expect with a radiculopathy, a single nerve root of loss of function.
Before we go into the intricacies of diagnosing and classifying, is there anything else with screening and stewarding that you wanted to bring up?
I think it's difficult because like you could open up the whole topic, like cord equina syndrome, all that stuff. But I think when it comes to the neuro exam, it's worth mentioning maybe something like gait disturbance is, I would think of as part of the neurological exam, or upper motor neuron signs. Because they do kind of come up, they're very much packaged with the neuro exam. Upper motor neuron signs are, I'm just stopping to think, how much do I go into this? You must stop me if you feel like I'm going in the wrong direction. But, broadly speaking, when we're, as clinicians, we are used to dealing with people who have lower motor neuron problems, whether it's at a nerve root, a nerve trunk, in the sciatic nerve, peripheral nerve, of neuropathy, that kind of thing. We're used to that kind of thing, and we, to a certain extent, we know what red flags to look out for, and we can steward our patients through a peripheral nerve problem, a lower motor neuron problem. An upper motor neuron problem is, of course, outside of our area of expertise. If something's going on in the brain or the spinal cord, and we're the first people to notice it, then someone else needs to take a look. Broadly speaking, the upper motor neurons put the brakes on lower motor neurons. So, this is the stuff that I remember learning like in great detail in PT school, of like exactly how upper motor neurons and lower motor neurons interact. But broadly speaking, when it comes to the neuro exam, the good thing to know is that the upper motor neurons are modulating the lower motor neurons, and they usually do it by putting the brakes on things. So let me explain in a bit more detail, a bit more clearly, hopefully. When people have upper motor neuron problems and the upper motor neurons are kind of, let's just say, knocked out or not working, then the lower motor neurons start to do more. They become more active. So when you test their reflex, they might have a very brisk reflex. They might have hyperreflexia. They might have high muscle tone. And when you test their Babinski sign, then they might have that upgoing Babinski. So you're on the lookout for, I guess the key thing is hyperreflexia. For most of our patients is what it's going to manifest as. That kind of, and the mnemonic that I like to use is, with upper motor neuron stuff, it's all up signs. So upgoing Babinski, hyperreflexia, and high tone. And for lower motor neuron stuff, i.e. our comfort tone, it's down, down, down stuff. So downgoing Babinski, muscle weakness or low tone, and reflexes are depressed, there's less reflex. So anytime you're doing the neuro exam and everything's kind of jumpy and there's more stuff going on, you might have to consider that there's an upper motor neurons problem, which is taking the brakes off those lower motor neurons.
Yeah, we'll circle back to the Babinski and some of those other pathological reflexes towards the end, and maybe that will bring us back as well to upper motor neuron. Yeah, thanks for bringing that up. And that up versus down, down, down is helpful, just as kind of a general way of thinking about it as a outpatient orthopedic clinician that's going to see mainly those of the latter. Let's go into diagnosing and classifying. Let's again start very basic, like why is it important, and then dive into those 4 diagnostic buckets that you mentioned in the book.
So I think I have to rein myself in. I think, why is it important? Because I love these kind of philosophical go nowhere discussions about, oh, well, it's good to know this, but also it's not worth knowing that. And of course, it depends who you are, whether you need to know what's wrong with someone. But generally speaking, you need to be able to have a provisional diagnosis to move forward as a clinician. So that you can tell your patient what you think is wrong with them. They have a right to know that, and it's often therapeutic to know that. And B, so that you can look out for specific aspects of therapy to do with that condition. So if a provisional diagnosis of sciatica, you might consider certain exercises, certain medications, and if things are bad enough, things like injections and operations, which you wouldn't consider if they had a peripheral mononeuropathy, for example. So that said, I kind of, as you say, in the zine at least, I talk about putting people into these buckets to kind of encourage the idea that, especially when we first see someone, what we're doing is necessarily crudely categorizing them in order to move forward with what we want to do. We're not kind of giving them this, obviously we can sometimes, but we're not trying to give them this precise diagnosis that we're going to kind of get too attached to, and that hopefully they would get too attached to. We're just trying to put them in this bucket. And when it comes to the neurological exam, we're trying to work out if we should put them in one of 4 buckets, one being radiculopathy, so a lumbar radiculopathy, aka sciatica. Another being a peripheral mononeuropathy, which would be things like a sciatic neuropathy, myalgia paresthetica, common perineal neuropathy. And the mono there just means one nerve is affected, the lateral femoral cutaneous nerve, the sciatic nerve, as opposed to the third bucket, which is a polyneuropathy, in which many nerves are affected, typically because of a systemic problem. So someone might have had chemotherapy, and they have diabetes, alcohol misuse, things that affect by one mechanism or another, basically all the nerves in the body. But most of these conditions affect the long nerves going into the feet and the hands first, because those nerves are furthest from the dorsal root ganglion, which maintains nerves. That's up in the spine. So, for example, if someone has diabetic neuropathy, they have often comes in the feet first, and sometimes the feet and hands, that glove and stocking distribution, which can masquerade or can look like more of a musculoskeletal problem. So the third bucket we want to put them into, based on what we see in our neuro exam, is this more of a pattern of peripheral, of a systemic polyneuropathy? And in the fourth bucket, I just kind of wryly call like not anopathy, which is when probably should be the biggest bucket, because we need to kind of chuck most people in there. This is not very like PC language, putting people into buckets, but which is lots of people have a bit of numbness on their knee because they had a total knee replacement or some sort of operation. Lots of people don't really know which part of the leg you're touching, just because they're in so much pain, they can't focus on it properly. Lots of people have reflex issues, what muscles that are weak on one side and not the other. And these people don't have, they don't fit any pattern because they don't have any diagnosable nerve issue. It's just kind of a rag-bag bunch of stuff that can show us some nerve loss of function when we do the exam, but is not something we can or would even want to diagnose as an issue. But it's really important to be aware that, if anything, that is the vast majority of people who have a loss of nerve function, is that it's kind of, we can just say maybe incidental or related to something else.
The radiculopathy we'll start with. There's different types of lower limb radiculopathies. Can you discuss how we would assess for them? And then I know you'd created a mnemonic for remembering these kind of levels.
Yeah. So in terms of assessing for radiculopathy, I think obviously we want to kind of embed this in like the broader clinical reasoning, and I'm just hesitating in case I repeat too much from the previous podcast. But we want to be considering whether the pattern of spinal and leg pain is radicular, that kind of severe, often reasonably specifically delineated pain that's worse below the knee, often comes with pins and needles and tingling, that kind of thing. The classic radicular pain pattern, or whether their pain is more referred, which is much more common, which is when you have pain in your back that kind of creeps or jumps down your leg and usually doesn't get past the knee and is kind of worse in the buttock and the thigh, and is that kind of aching, gnawing pain that people can't really put their finger on. When it comes to, obviously we want to kind of tease out people's history and things, and find out what the pattern is. One of the things that comes through the neuro exam is, I generally kind of deter too much. I speak about myself, like I don't worry too much about what level someone's problem is, because I think there's literally no reason I can think of for me to need to know that. The only person who would want to know that is someone who'd want to operate or inject their spine, I think. That said, I think it's extremely valuable to have an idea of what the different levels of radiculopathy look like, because our job in diagnosing and classifying people means that we have to have those classic patterns in our head so that we can say whether our patient is showing us something like that classic pattern. So I think of us as kind of our job is approximating our patient's presentation to the classic or textbook patterns that we know, as a kind of pattern matching or pattern approximation. So I think it's really useful to have a clear idea or characterization, something in your mind's eye of each level of radiculopathy, so that even if, more likely when, our patient doesn't perfectly match it, we can say that's pretty much that. It looks pretty much the same, and it definitely doesn't look like any of this other stuff. And then we can say, for now, I'm going to say this is a radiculopathy, probably L5, and then we can move forward. I'm always curious talking to people about the levels of radiculopathy, because for some people it seems to sink in quite easily. Like a level L5 looks like this, and I can only confess that for me it took so long to kind of get this is L5, this is S1. Mnemonics are most useful when you make up your own, because it's personal to you, but maybe it will be useful for me to say mine. Although I'll briefly kind of say that, we've talked about S1 and L5 radiculopathy, and for L3 and L4, which are much less common, I can lump them together as like an upper lumbar radiculopathy. So I think of kind of three kinds of radiculopathy. For the upper lumbar radiculopathy, please interrupt me, Chris, if I'm giving like too much detail or just or not enough. For the upper lumbar radiculopathy, the loss of sensation that we expect to see is on the front of the knee and kind of tracking down to the middle of the calf. Now, this is we could debate dermatome maps. This is the most evidence-based kind of summary that we have. The loss of strength that we expect to see is in knee extension, and the loss of the reflex is a patellar reflex, the knee jerk. So the way I always remember those is it's kind of the knee radiculopathy. The upper lumbar radiculopathy, everything is to do with the knee. It's the knee jerk, it's the quad extension, and it's a loss of sensation on the front of the knee, then tracking down to the medial calf. So, knee rhymes with 3, L3. That's kind of a way to remember it, I suppose. Or L4, there's 4 quads, makes you think of the knee as well. So it helps to kind of just turn this thing over in your mind from different directions, and then you kind of get almost like a character. This is the upper lumbar radiculopathy. That's really rare, of course, the upper lumbar radiculopathy. More common is the L5 and S1. L5, whereas kind of the upper lumbar is, I always kind of think is to do with the knee. L5 is basically everything to do with the top of the foot. So the loss of sensation is the dorsum of the foot, and then tracking up to the kind of anterolateral leg. The loss of strength is dorsiflexion. So you think of the top of the foot moving up with knee extension, which doesn't really fit the mnemonic, but it's like kicking a ball, dorsiflexion, knee extension. And the loss of reflex is actually not relevant. There's not really a L5 reflex that people usually test. The L5 reflex is the medial hamstrings. People don't really test it because it's really awkward and it doesn't really add much. And then the Achilles, I always think it's everything to do with the Achilles. I should say the little mnemonic is, for L5, top of the foot, there's 5 toes. So that takes my mind's eye down to my 5 toes. The S1 looks like the Achilles looks like a big number 1. So it takes my mind's eye down to the Achilles. And of course, S1 is your ankle jerk. It's your plantar flexion. And the loss of sensation doesn't really fit. It's the lateral border of the foot and then going up the back of the leg. But your mind's eye is down there with the Achilles, and you kind of bundle everything together. So those are the kind of platonic ideals of the 3 lower limb radiculopathies. When it comes to the neuro exam, it may not present exactly like that, but we can say this is fitting pretty much an S1 radiculopathy and not the other things, and that helps us move forward.
Yeah, I'm on the boat where it took me and still takes me forever to like mentally think through those. So I appreciate your own kind of mental picture mnemonic. Yeah. You already kind of touched on the mononeuropathies, polyneuropathies, and then nodenopathy. Anything else in this kind of diagnosing and classifying category you want to touch on besides what we already did before we go into some of the actual sensation testing?
I think I'm conscious like we could talk more, but I don't want to go on too much. And people, like I say, I'll make the zine free. People can just go and read it. But I think that maybe the main thing to say is, that there are maybe 4 mononeuropathies. I mentioned them earlier, which are common. I shouldn't say they're common. They're most common, and there's reasonably common types of polyneuropathy. I think that the potential here is that, I'm talking a lot, like I like this stuff, so just talk about it endlessly. But this is not Dr. House stuff, This is not that difficult. Of course, it sometimes is, especially when people have they're in a great deal of pain or they have other medical conditions. It is often difficult to tease this stuff out. But everything that I'm saying, like the theory and the textbook stuff, I don't want to give the impression that we're doing Dr. House type technical stuff. It might feel like that at first, but once you've got reps under your belt, the patterns that you uncover in the neurological exam are reasonably clear. I'm not trying to imply it's really hard or technical to put people in these buckets. Not least because, especially, the kind of other mononeuropathies are not that common. Sciatic neuropathy is not that common. Perineal neuropathy is not. Lateral femoral cutaneous nerve. So it's not like we're getting like tons of stuff coming at us. Radiculopathy is reasonably common. And some of the other stuff that I mentioned that it could be, especially once people have seen a doctor before they get to us, it's not that common that people are going to have this stuff. We just need to be aware of it and aware of the patterns so that we can match to those patterns or approximate those patterns when we see them. But I'm not trying to imply that this shouldn't be too difficult. You know what I mean? Yeah.
Let's go into sensation testing. What does a good sensory test look like? And I know you chunked it out in the zine as sensation, strength, reflex. Maybe you can touch on when you were practicing and recommendations for clinicians, like the logical flow of these different types of exams. Do you recommend starting with sensation, then strength, then reflex? Anything you want to kind of touch on, just the flow of this entire neuro exam?
So I think, in my opinion, I don't think flow matters. I think you could certainly make arguments for this or the other. Maybe it's good to leave the straight leg raise, which we haven't mentioned yet, till last, because that can kind of really irritate people. If people are in a great deal of pain, maybe you could argue you leave the muscle strength testing till last, because that might wind them up into more pain. But I think generally speaking, like the kind of rule of thumb, or like the fallback rule for a lot of this stuff, is just do what you do. Because if you have your habits, should you put someone's head on a pillow to straight leg raise them or not? And it's kind of, you could argue the toss, but basically you do what you do so that you're used to it and you know what a baseline is. And you kind of, I wouldn't really argue for one order over another. Would you, Chris, out of interest?
I don't think so. Yeah, I think it's what I mentioned earlier, like the comfortability and the confidence that you're portraying throughout the clinical exam of it's obvious that you've done this before and that there is a coherent flow, whatever that may be, but the specific actual direction in which specific clinicians go with it, I think there's probably a lot of variability that you can have.
Okay, cool. So we're in agreement. Your listeners thought we might get like a juicy argument or something there, but you have to disagree with me about something later, and then.
All right, I'll try.
But for the sensory exam, this is another one of those ones where it's kind of how precise do you need to be, so that there are quantitative sensory testing methods involving like neuro filaments and stuff, which I will say I've never used. I don't even quite remember what it's called, but the filaments that exactly, von Frey filament. And then there is the, in the NHS, we used to call it like the classic surgeon's exam, where just like through trousers, through pants, the surgeon just goes like this down the leg and sort of seems fine. Maybe somewhere in the middle. The interesting questions are, well, basically, what are you trying to do? You're touching your patient's skin to see if they can feel it. Because if they can feel it, then that implies that the impulses, action potentials, are getting all the way up to their brain, and there's nothing wrong with their sensory system. If they can't feel it, then that implies that the impulses are getting blocked somewhere up on the way to the brain. Maybe it's the nerve root, maybe it's the sciatic nerve, but there's something wrong, a conduction block. Typically, or often what you see is people testing with their hands. So, okay, can you maybe strip to your shorts or your underwear, and then they'll test sensation with their hands. To be honest, I think that's quite reasonable. But some people argue that we should not do that because our hands have a temperature, which means we're actually testing thermal sensation. Our hands might be hot or cold. What we want to be testing is light touch sensation. Now, in that case, some people, including me, say you should just get a pack of cotton buds off Amazon if you don't have them already, or cotton balls, and test with those. If anything, it looks very impressive to the patient as well when you get your cotton ball out. But it's definitely an easy way to do something that is better than using your hands, is to get some cotton buds and test in that way. Some people, many people will test according to the dermatomes. That's how I was taught to test. So you test, okay, I'm now testing L4, L3, or L5, S1. Again, I think that's perfectly reasonable. Some people will say that ideally you should test in kind of hoops around the limb. So 2 hoops around the upper arm, hoops or loops, 1, 2 around the lower arm, and then the top and bottom of each finger or toe. The reason being, I suppose 2 reasons. One is that if you test dermatomes, arguably like you're biasing yourself. You're saying, okay, I'm going to go looking for something. I'm going to go look for, you're biasing your test. I'm going to go looking for loss of dermatome function when they might not have that. And the other is that it's a little bit, it's a little bit more rigorous, arguably, kind of if you cover the territory like that. So I argue for that. I think that if you can, then just to test in 2 loops or rings around kind of the upper limb, the upper leg, and then the lower leg, and then the top of each toe is probably a slightly better way to do it. But again, let's say you can't lift their leg up or they're in too much pain to get in a certain position. as long as you cover the skin, that's the main thing. Another thing people say, and again, I agree with this, is that you should test someone's pinprick sensation. So when we test with our hands or a cotton bud, we're testing their light touch sensation. Are the impulses of a light touch getting up to their brain? But light touch is carried by the large nerve fibers, the A beta fibers. And the small nerve fibers don't care at all about light touch. They're completely impervious to it. They're not interested. This is the part where I have to say, of course, it's like a continuum, but broadly speaking. So you say, in that case, we're only testing like half of the nerve fiber population if we're just testing light touch. So we should get out something sharp and test pinprick or noxious sensation as well. And then we're testing at least some of the small fibers as well. And it's true, often this does uncover lost sensation that you may not have seen before. I think it's a good habit to get into. As I say, it adds to the picture. Patients are often very interested in it and what you're doing. Maybe it's just kind of, patients that I see, but they're interested in that, and you uncover like a little patch of sensation, and it helps them to learn more about what's going on. And sometimes it does kind of push you in one direction more than the other. But again, broadly speaking, this depends who you are. If you're like in a specialist nerve injury clinic, you're already doing this. I'm telling you things you know. But if you're already all the way on the other end and you're like a sports therapist or something who just wants to get your patient strong and make sure there's nothing wrong with the neuro exam, you probably don't want to do this. Somewhere in the middle, or wherever you fall in that continuum. And just the last thing to say about that is if you're using, get some neuro tips off Amazon. Again, they're pretty cheap. And if you just use the other end of your reflex hammer, which is often pointed, make sure it is pointed, because usually it's not actually pointy. Like they put like a point on it to pretend that you can use it for this function, but usually the point isn't pointy. So be aware of that. But that's obviously, there's more on sensory testing, but aware that I've been, do you want me, I can go in any direction, Chris?
Yeah, the other thing is like comparing to the other side, and then the logistics of how are you describing it to the patient? Like, what are you saying to them, and a little bit of that kind of actual flow.
Right. So thank you. So as I say, the goal is to say, okay, can your patient feel it when you touch their skin? And in order to know where they can feel it, you want to test one leg to the other. So typically someone will have pain in the left leg or right leg. Let's say someone has pain in the left leg. You want to test the right leg first to get an idea of what their normal is, and then test the sensation on the left leg. And if you find something on the left leg, then you can kind of be comparing one to the other. Okay. And you want to loosely quantify it. So you can say, okay, so this is 100%, or this is 10 out of 10 on your right leg. Well, how does it feel on your left leg? Say, I don't know, 5 out of 10. It's totally subjective, but you have something. And then you can know if it's getting better or worse, roughly. So some people, of course, might have pain in both legs, or you might suspect you're looking at a loss of function in both legs. Maybe they could have a polyneuropathy, they have diabetes or something. So maybe you're worried that they just have poor sensation in both feet anyway. In which case, choose a patch of skin on their thigh or their abdomen to compare against instead of the opposite leg. So that's what you want to do. You want to map it out with those kind of, top to bottom, scan it basically. Yeah, scan it down. And then, if you do find an area, map that area out. Make a note of, loosely quantify the degree of lost sensation. And make a note as well as like this area that you've mapped out, is it a very clearly delineated area of lost sensation, which typically you'd associate with a peripheral nerve problem. So again, like if it's neuralgia paresthetica, you get a fairly clearly delineated area of a lost sensation on the thigh. People will say, I can definitely feel it here, and I definitely can't feel it here. If it's sciatica, a nerve root problem, all the nerve roots basically share work. So one nerve root that might be hurt in the spine, by the time those nerve fibers get down into your foot, they're sharing the work of most stuff they do with the fibers from the neighboring roots. So the roots jumble together in the plexus. Put it that way, all the roots are going to jumble together and then go out into the peripheral nerves and share work, which means that when people have a loss of sensation with a nerve root problem, is typically that boundaries might be a bit fuzzy, and it's often not like a complete loss of sensation. It's like a partial loss. Same with the strength. You know, if someone has like a peripheral nerve injury, if it's bad enough, it's just like cutting the wire on a TV. They just lose all sensation, all strength. But if someone has a nerve root injury, then typically the other neighboring roots can compensate for that muscle's function. So, you know, if someone has even a really serious L4 radiculopathy, then, you know, L2 and L3 can probably do some work of the quads. They're not going to have like a floppy limb because their quads are totally knocked out. That's like a general rule, is like really serious loss of function tends generally to imply like a peripheral nerve trunk problem. The exception being like a foot drop, which is L4 and L5. There's only two roots doing that, and L5 is usually doing most of it. So often you do get like a completely floppy foot if someone has an L5 radiculopathy. Yeah. I'm glad I said that people could like get the zine, because I'm conscious that like it's very difficult to picture some of this in your mind's eye, I think.
Sure.
I mean, I'm doing like waving my hands around to help me kind of work out what I'm saying. So if people are listening to this on their headphones, yeah, it's quite tricky to follow.
Look at the zine at the same
I haven't
time.
lost anyone. Yeah.
Let's dive into strength testing. Similar question with sensation as well. What does a good motor strength test look like?
I think it's, you know, the basic stuff like making sure the patient's comfortable, testing the muscle in, you know, roughly the mid position. It can be tricky saying stuff like, okay, push up and out, you know, with your ankle, or something like that. An easy way to do it is to just position your patient's muscle roughly in the mid position and say, don't let me move you. So you push them in the direction you want them to go, whether it's their ankle or their knee. They don't let me move you. And that's like an easy instruction for them to follow. In terms of applying force, I generally say like apply it reasonably gradually. Don't just kind of push. Don't surprise them with the force. Reasonably gradually and for a sustained few seconds, so that they have time to work out what you're doing and the muscles have time to recruit. You know, I think in terms of like exactly how to test the muscles, there's 100 YouTube videos on and podcast is not the best way anyway to say that the positions. Sometimes people are quite strong, and if you want to dig a little bit more, you can ask them to do like a single leg squat. There's some research out there to show that that's pretty good at identifying people with a upper lumbar radiculopathy, or a heel raise, and then comparing one side to the other. Again, some research to show that does work in stronger people to differentiate or to identify a S1 radiculopathy. If people are stronger, you need to get them to just do a body weight exercise, basically.
I think you had mentioned this earlier on, the Oxford grading system. So when we're taught it in school, there's like 1,000 different ways you can grade it, and then the intricacies of 4+, 4-, 4.
Yeah.
What's your overall stance on how it should be graded?
So I think I don't know if I'm stepping into any controversy here. My impression is no one really cares about it. It's so boring. But I don't think there's any particular value to a plus. If I can just you know, people say, and they're right, the problem with the Oxford grading scale is that it's all 4. 96% of like a muscle's function or range of possible function from not being able to move to full strength is 4. I.e. being able to contract against resistance. And by which I mean, if you add resistance to someone's dorsiflexion, it could be very weak, but that's still a 4. They can contract against you. Or you could be putting your whole body weight into it and they can contract against that. But as long as it's less than the other leg, that's still a 4, So some people say, okay, well, maybe we basically split 4 into 2. There's 4 and 4 plus, which is absolutely completely reasonable and defensible. But my understanding of the evidence, with the full disclosure that I haven't spent nights awake reading it because it's so boring, is that adding a plus, like a 4 plus, meaning the upper bounds of 4, potentially confuses things and doesn't help, and doesn't have the inter-rater reliability that you would want. And the reason, so I kind of default on just like, don't worry about making it plus whatever, because it's important, like with the buckets, to come back and remember this is all extremely subjective. Maybe not everything is subjective, but much of this is very subjective, especially like how you rate your patient's strength based on how you did the test and the effort they put into the test based on your instructions and their pain. So look, again, getting back to what do we want to do? Diagnose and classify, screen and steward, reassure and educate. So in that sense, we want to kind of keep it relatively simple, I think. And again, if you disagree, let me know.
No, I agree. I don't think it matters a ton with the nitty gritty for all the reasons you mentioned. Reflex testing. Yep. Again, what is a good reflex test? Things that you think people are obviously doing wrong, or just common mistakes that we can avoid?
I think with the reflex testing, again, I don't know, but this is something people get wrong too much, to be honest. I think it's pretty straightforward. Again, muscle in comfortable or mid position, palpate to find the tendon. Sometimes you see people kind of knocking on bones and stuff. And then just like a brisk tap and a few little taps and see if there's a reflex there. And in terms of positioning, just whatever is comfortable or that you're used to. Sometimes, of course, it's difficult to elicit a reflex, in which case, broadly speaking, you want to get your patient to contract a muscle distal to the reflex, which sounds like some kind of mumbo jumbo kind of, but apparently it works, and there's evidence to show that it works, the Jendrisic maneuver. So it works better on the patella than the Achilles reflex. If you can't elicit the reflex, get them to, lock their fingers together and pull their fingers apart, maybe grit their teeth as well. And then that kind of supposedly relaxes their quad muscle so that you can get the reflex better. And in terms of the Achilles, if you can't elicit it, have them sort of high kneeling on a chair, if it's comfortable for them, of course. And then that can help you to elicit the reflex if they're kind of kneeling up and you're tapping on the Achilles that way. But, with reflexes, you've got the L5 reflex down there in the hamstring, which again, I said, is probably not something to worry about. I certainly almost never did it. And then with reflexes, it's mostly about interpretation. So obviously there's a potential that someone might have very brisk reflexes or a brisk reflex. As I mentioned before, we put that in the up signs of like an upper motor neuron sign. So let's say you test their patellar reflex and their whole leg jerks off the plinth. We'd call that kind of a brisk or hyperreflexive reflex. And that makes you raise an eyebrow. Again, you're not pressing that red button and picking up the phone, but it raises an eyebrow. What's going on here? Why is this person's reflex so brisk? But of course, whether it's brisk depends on comparing to the other side and also just their other reflexes. So most people with a brisk reflex will be broadly hyperreflexive. So that it will be the same on the other side, and then their upper limb, they just have hyperreflexia. So, it'll just smoke without fire. And again, with the lower limb, if someone has one lost reflex, it's probably just smoke without fire, especially if you're not matching it to any pattern. There's no loss of sensation or no loss of sensation that matches a radiculopathy or a peripheral neuropathy. So a lost or a dull reflex in itself is not concerning unless it fits that clinical picture. And, as people get older, I think it's about 25% of people over 60 have bilateral loss of Achilles reflex. So you expect it as people get older as well. So that's broadly it for reflexes. I looked into the evidence for all this. There's quite a lot of interesting research on the neurological exam, and the reflex is the most kind of specific and sensitive of the neuro stuff, meaning compared to strength and sensation. Pretty consistently, it does better on sensitivity and specificity tests. So that means that if you do see a lost reflex, you should consider putting some stock into it. But generally speaking, like any, I was reading this, I don't know if people really say this, but I was reading this paper where it said that neurologists have an ignore one finding rule. And an ignore one finding rule is probably quite sensible with some discretion, that if you see one thing wrong, it's probably not much to worry about.
Let's end with the pathological reflexes. And I'm curious if the ignore one finding applies to the pathological reflexes. You had briefly mentioned the Babinski early on, but Hoffman's, Clonus, Babinski, what are pathological reflexes, and then what is it suggesting?
So the pathological reflexes are, to me, that it was a bit like kind of differentiating between different levels of radiculopathy. It took me the longest time to feel comfortable with them because they seem kind of like magic. Like, why on earth does the Hoffman's reflex, like if you flick one digit, why does the other digit also contract? The Clonus, if you kind of push down, again, people can look on how to do these on YouTube, but why would someone's knee just kind of jiggle endlessly if you did Clonus? Hoffman's and Clonus are just examples of hyperreflexia. So they are examples of people's reflexes people have the brakes taken off their reflexes. So we go back again to the upper motor neuron stuff. Upper motor neurons put the brakes on lower motor neurons. When there's something wrong with an upper motor neuron, then the lower motor neuron just goes crazy. That's how I think of it. And the reflexes become very brisk. I should mention, as an aside, an interesting phenomenon is reflex irradiation or reflex spread, where if you test one reflex, say the ankle jerk, then it makes the whole leg and all the other muscles in the leg jerk, because one reflex triggers another reflex, triggers another reflex. So hyperreflexia can manifest as one very brisk reflex. It can manifest as reflex irradiation, where one reflex triggers all the other reflexes on that limb. Or it can manifest as clonus, where if you trigger someone's calf reflex with a quick jerk of their ankle, and then you set off kind of the calf sets off its own reflex, basically. It's so hyperreflexive, it's so sensitive to movement, that its own movement sets off its own reflex. So you get this kind of recursive or repeating reflex. Same with Hoffman's. If you flick someone's digit, then it can make another digit contract if they're hyperreflexive. The vibration from one movement spreads to another muscle. So basically, I think Hoffman's and Clonus, you're just testing for hyperreflexia. Babinski is one of the true mysterious, that is. In reading about this, I found out that neurologists are very snooty and protective about Babinski. They love their Babinski. It's quite sweet, really. They love Babinski reflex, and they consider it to be like an S tier. Like if you compare Babinski to something as crude as a Hoffman's reflex, I think some neurologists get. So Babinski is up on this podium as this kind of special, and it is such an odd reflex. You're scratching the bottom of your patient's foot, and it can be upgoing, which means they might have an upper motor neuron problem, which, i.e. their big toe goes up and the other digits fan out, or it can be downgoing, which is a pretty normal response. So again, this this was completely mysterious, baffling sort of occult magic to me until I looked into it. The explanation for Babinski's test that Babinski gave is that it is a Babinski's sign, i.e. the upgoing Babinski, is a whole limb response to a noxious stimulus, i.e. it's a withdrawal response. I was like, oh, that makes sense. So you're basically scratching the foot and people are moving away from the scratch, which is a totally natural thing to do. The Babinski sign, like that upgoing withdrawal reflex, is present in mammals. It's present in neonates, little babies, as people know. But as we get older, our upper motor neurons function better and they suppress that reflex. So if I do Babinski's test on you, Chris, you don't have that. I hope you don't have that upgoing response because the upper motor neurons put the brakes on it as we kind of mature. It's like a primitive reflex that we essentially outgrow. Our nervous system outgrows it. If you have an upper motor neuron problem, then you will have that positive upgoing Babinski, which, as I said, Babinski theorized is a whole limb withdrawal response from a noxious stimulus, but which is often only visible at the toes, the big toes. So we see the big toe going up. But Babinski was very keen on this idea that actually, if you really observe closely, you can see the whole limb kind of shifting out the way. It's just the toe is the most obvious movement. In healthy people, of course, we often see a downgoing response, which is just ticklishness, basically. You're just tickling the feet. And so people kind of cringe in on the ticklish. But it does have to be a noxious stimulus. So something sharp, like a pin or something like that. And you do have to use the lateral border of the foot. So you're not the flexor hallucis longus tendon. You want to not scratch that, apparently. And you're kind of scratching the lateral border of the foot to see if you get that big toe, and possibly if you're keen enough to see it, the whole limb response withdrawal from the noxious stimulus.
And because these, if they are positive and they're suggestive of potential upper motor neuron potential diagnoses or pathology, would you expect both sides to be positive? And then if all the other, which I'm assuming this wouldn't be the case, but let's say everything else, like nothing stood out to you as concerning during a neuro exam, but then they have these pathological reflexes, either one or multiple, are you then gonna like kind of second guess the rest of your neuro exam and refer out? Have you ever even like heard or seen that?
I'm trying not to like retreat into or put everything into context. I think the ignore one finding rule probably you can apply to Babinski if you're really reassured by the clinical picture. Obviously there's something wrong if you're doing the test at all, but I think it's a, put it this way, it's a sensitive test. No, it's not. That's completely wrong. It's not a sensitive test, which is actually in a way not what we want, because it's not an ideal screening test. So in other words, it's not that reassuring if someone doesn't have it. It's quite common for people who do have upper motor neuron problems to have a negative or Babinski test. But it is a specific test, which means when you see a positive Babinski test, it generally means there is something wrong. So from that point of view, you'd say, okay, you do put more stock in it, and maybe you don't want to just ignore it, And the other thing to say is, okay, well, what is a positive test? Because often, it's does it mean it's repeated positive over and over again, which is obviously more convincing than if it's positive once and then you do it again and you're not sure what you're seeing, and then you do it again, it's negative. If it's repeated positive over and over again on both sides, then that's obviously more concerning than if it's ambiguous or intermittently positive. So, I'm trying to not sit on the fence, but I would say it's actually, if you can clinically reason it and your patient is kind of their gait is fine. Their Romberg's is negative. They don't have the kind of any ataxia in their gait. They don't have any other hyperreflexia. They're not the type of, they don't have a clinical history that might make you worry about this or that. And then conversely, if they're really strongly fitting a problem that you're comfortable with, if they're really strongly matching to that pattern of an S1 radiculopathy, then I think there's certainly situations where you can ignore a Babinski test. Whether I have to ask my lawyers to get you to take that out of the podcast, I don't know. But you know what I mean? Like you can certainly ignore it if you can reason it and, defend that reasoning in your notes,
I have one more area that I'd be curious to hear how you would describe it, but you've gone through an extensive neuro exam with this patient. Before that, you've gone through just a history and subjective, and a lot of information is gathered from that as well, obviously. For the cases where you feel comfortable and confident moving forward with physical therapy, how would you, maybe we stick with radiculopathy, how would you discuss some of the findings and that kind of reassurance piece and wrapping it up towards the end of an examination? And then maybe on the contrary, there are things that you're seeing that actually you want to refer out, or that are maybe these upper motor neuron signs. How would you have that type of conversation? Can you maybe discuss those two separate, and then we'll probably wrap it up there?
I think it depends what the patient's starting position and level of anxiety is, because there are patients who should be more worried than they are. But broadly speaking, most people would benefit from being less worried. If someone has some findings on the neurological exam, but I'm not worried about them, I like to take time to explain what's happening. Okay, if I touch this leg and it's not your non-painful leg, and if I touch the skin here, you can feel that because it sends a little signal up to your brain and you know that I'm touching your leg. But if I touch the other leg here, you can't feel it as well. And I think it's because that signal is getting blocked on the way to your brain. Excuse me. And from what I can see, it's probably a nerve in your spine is where that signal is not getting through. We're going to keep an eye on that because whenever there's a nerve problem, we want to take it quite seriously. Having said that, I do see this all the time. I see whatever you want to say, where I see this 5 times a week. And in that sense, I'm not concerned. We would expect an irritated nerve to not work as well, and we expect it to get healthier again and start to work as well. So we're going to keep an eye on it, make sure it doesn't get worse. That kind of explanation, whatever's natural to you. So I guess it's that kind of balance of, this is normal. It's common. I've seen it a lot. And it's what we'd expect. Along with that, you're not dismissing it too much, because you're saying, you also need to kind of say, for most people, this is something that we do need to take seriously and keep an eye on. I'm going to take it seriously. It's my job now to steward your nerve health, and whether I'm going to call you on the phone next week or book you in for an appointment, we're just going to make sure that it hasn't got worse and nothing else has got worse too. And they need to take it seriously too, because it is quite surprising, again, how many people don't. I think, again, we are so used to this stuff, and we've got developed an intuition of what's bad and what's serious when it comes to nerve stuff and physio stuff. And it's quite surprising to me often how patients don't know when to worry about stuff. The classic one being, oh, now that you mention it, I've been wetting myself for a week, which sets off alarm bells in our head. But for some reason, many people just seem to be comfortable. So we're trying to establish that actually this is something for you to take seriously too. If there's something serious going on and I want to refer on, I think, again, it's so hard to give generic advice. It depends. Does this person need to be more worried or less worried? And what is it? How long do I expect them to be waiting? I think one of the key things with that is, again, to impress on them the seriousness of the situation. Say, because again, so many people have this kind of inertia when it comes to going to the next appointment or going to the emergency department, where they're like, oh, I'll leave it till tomorrow. And impress them, I'm actually worried about this. I think this might be going on. And also the other thing, kind of generic piece of advice I would give is to not, again, say it's quarter equina syndrome or something like that, because your neurological exam shows bilateral Achilles loss in a young person along with X, Y, and Z. To be quite clear that the person you're referring to, you're don't set up too many expectations about what that person will do. This might, this is maybe a very NHS specific bit of advice for various reasons, but if you refer someone to the emergency department for suspected quarter equina syndrome, I always say, don't tell them you're going for a scan. Don't tell them, okay, you're going to go and see someone and they'll give you a scan. Because that might be what you hope happens, but actually, that might not be what happens for various reasons. You don't want the patient to feel like they're being fobbed off or shortchanged because they don't get one. And at the end of the day, you are referring to someone who will take over for you, and it's their decision. So, I don't know, a very generic piece of advice is not to tell your patient this XYZ will happen. At the other end of that referral, say what might happen, but don't set them up for disappointment or failure or confusion.
That all makes sense. I know we've gone over an hour. Like you said, there's a lot of these where we could go even further, but how practical is that for this specific episode? And a lot of this is visual. So I think people either looking at the zine before, during, after the episode and printing it out and just having it in the clinic. Like if I was a student or even still, like just printing that out and having it close to me when I forget something, I want to refer back to something. Some of it actually may be helpful to like show a patient or walk through it or a student. So I highly recommend people get it. And Tom's offering it for free, so there's no excuse.
Yeah, I'll make the code E3Rehab with a lowercase e.
Okay, perfect. Yeah, we'll link.
Seeing if we've missed anything out.
It below. Yeah, anything else that you want to close out with as you skim through the scene?
No, just thanks for your time. I think I was quite pleased with how it went in terms of like, I feel like, sometimes, I think in terms of staying on track, I think I got a lot of what I wanted to say across. Just obviously concerned that a lot of it would do better with visuals, but I enjoyed that. Thanks, Chris, and invite me back again.
Sounds great, Tom. Yeah, next time it would have just been another rabbit hole, but there may be another episode where we dive into the straight leg raise and anything else that you've been writing. Would love that for round 3. Yep. All right, we'll call it there. Thanks, Tom.
Cool. Thanks, Chris.